here at SLC. I would like to extend our sincere thanks to our distinguished panel for setting aside some time today to be on this webinar and share their expertise with us. To begin, I would like to take care of a few housekeeping items. Everyone on the webinar today currently is in listen-only mode. For those who wish to ask a question, you may do so using the question box on your GoToWebinar toolbar. You may type in a question at any time during the presentations. Secondly, please remember we will be recording this webinar and posting it later on the CSG Knowledge Center website at knowledgecenter.csg.org. The webinar also will be available on the SLC website at slcatlanta.org. Today's discussion focuses on long-term care, frequently known as LTC or LTSS. Long-term care is broadly defined as a range of services that support those who are limited in their ability to care for themselves for a short or extended period of time. As many of us know, long-term care is a medical, fiscal, and policy concern, one that will grow in importance as America's demographics continue to change in the years ahead. With the continuing rise of people aged 65 and older, statistically the demographic most in need of long-term care, the ways in which we administer care for this cohort will become increasingly important. Today, many people do not have the financial resources to pay for long-term care, prompting them to turn to other sources for support, primarily Medicaid and unpaid caregiving from friends and family. With these concerns in mind, it is absolutely critical that states begin preparing for the growing pressures long-term care will place on their budgets in the years ahead. Here today to talk about the challenges posed by long-term care are three esteemed speakers. Our first speaker is Kathleen Uveri, Senior Policy Research Analyst from AARP's Public Policy Institute. Kathleen is a co-author of multiple publications that address long-term care, including long-term care insurance, the role of states in supporting caregivers, and long-term care financing. Our second speaker is Ann Tumlinson, CEO of Ann Tumlinson Innovations. Ann has more than 2 decades of research and consulting experience in post-acute and long-term care financing and delivery. She has testified before Congress and appeared before the Long-Term Care Commission, as well as the Bipartisan Policy Center. Our third speaker is Jeff Lunardi, Principal and Legislative Analyst with Virginia's Joint Legislative Audit and Review Commission, also known as JLARC. Jeff manages the design and execution of JLARC studies, which serve as a key component of the legislative oversight function in Virginia. And Jeff and Kathleen, thank you very much for being here today. Each presenter will speak for approximately 15 minutes. Please feel free to submit your questions as they come up throughout the program. We will answer as many questions as time permits at the end. With that, I now turn it over to Kathleen.
Thank you, Roger. Next slide, please. So during the next 15 minutes, I'm going to limit talking points to a very, very short list of 4 issues. There are so many more issues than 4, but the amount of time will limit it to 4. The first is demographics and how the aging population is growing at an incredibly dramatic rate. The second topic relates to family caregivers, who are the backbone of long-term services and supports, and how the supply of family caregivers is unlikely to keep pace with future demand. The third topic is expanding home and community-based services and why shifting Medicaid spending away from institutional care and toward HCBS initiatives is so very important. And then finally, I'll just touch on financing long-term services and supports and solutions that are needed to address the potentially catastrophic costs of LTSS. Next slide, please. So the age 85 and older population is growing at a really, really dramatic rate. This is the baby boom population. This demographic phenomenon has a significant impact on every aspect of society, which really ranges from our healthcare system to the broader economy. People age 85 and older are the group who are most likely to need long-term services and supports to help them with their everyday tasks. They not only have higher rates of disability than younger people, but about 1/3 of people who are over age 85 have dementia. And this population is also more likely to be living alone without a spouse or other family member to provide them with any kind of assistance. When do baby boomers turn age 85? Sadly, it's in just 14 years. 2031 sounds like a long way off, but it's really just 14 years away. States are undertaking significant changes in the way they deliver and fund services and supports for today's older adults. But the question is, will states be equipped to address the needs of the growing aging population in the not too distant future? And again, that's just 14 years away. Next slide, please. So this slide shows the projected skyrocketing rate of the age 85 plus population. From 2015 to 2050, the age 85 plus population will more than triple. It's the fastest age group over that time period. So this is the dark blue line that's skyrocketing over to the right. So how does the growth in the older populations compare to younger populations? Well, the age 65 and older population is going to grow much faster than the younger age groups. So all three of the older age groups, so that would be the 65 to 74, 75 to 84, and then the 85 plus, will more than double between 2015 and 2050. While the younger age groups, so that's the age up to age 17, the 18 to 49, and then the 50 to 64, will increase only very, very slightly. So the growth in the age 85 and older population will start to significantly outpace all other age groups once those boomers begin to turn 85 after the year 2030. And today, people who are age 85 and older make up just 2% of the U.S. population. However, by 2050, this population is going to represent almost 5% of the population. But of course, there are significant variations by state. The next slide, please. So this graph shows 7 southern states. That's Florida, Georgia, North Carolina, South Carolina, Tennessee, Texas, and Virginia, which have the largest projected percentage change in the age 85 and older population from 2015 to 2015. And these states have projected increases of anywhere between 200 and 315%. The states with the most significant percentage changes include Georgia with a 315% change, Texas at 284%, and Virginia at 282. Now, Florida is the state with the largest population of people age 85 and older. And it is projected to continue to trend in this fashion all the way up through 2050, with a projected increase in the age 85 plus population of just about 200%. So next slide, please. So this bar graph shows the projected percentage change in the 85 and older population for all 15 states through 2015. And I selected these states as this is the coverage area for the Southern Legislative Conference of the Council of State Governments. So it's, it may not represent all states that some of us may view as Southern, but these are the ones that I was informed would be most likely to be covered for this particular conference. And the states are ordered in this graph by largest to smallest projected percentage change in the population growth. So Georgia, Texas, and Virginia, as I mentioned, have projected percentage increases in excess of 275% collectively, while Arkansas, Oklahoma, and West Virginia have projected percentage increases of 160% or less, which is still a significant increase in this 85-plus population, as it does represent more than double the age 85 population in 2015. So now I'd like to turn attention to the supply of family caregivers. So next slide, please. So the "you take care of mom, but who will take care of you" message that was included in an AARP blog written a few years ago is still very, very current. Unpaid family caregivers provide the majority of care for those who need long-term services and support. And for this reason, family caregivers are, as I mentioned earlier, cited as the backbone of long-term services and supports. What we find, however, is that the supply of family caregivers is unlikely to keep pace with future demand for their needs. The family caregiver support ratio is defined as the number of potential family caregivers who are mostly adult children in age 45 to 64 for each person age 80 plus. Now I've been talking about the 85 plus population, but for purposes of this ratio, we include the age 80 plus population. So this ratio is used to estimate the availability of family caregivers during the next few decades. And based on AARP calculations, the ratio of potential family caregivers to the growing number of older adults will see a very, very steep decline in the future. So in 2015, there were almost 7 potential family caregivers for every person in this high-risk age bracket of 80 plus. And then when we move to 2030, about the time that the baby boomers are going to start turning age 85, this ratio is projected to decline sharply to 4 to 1. And then it's expected to further fall to less than 3 family caregivers for each person age 80 and older in the year 2050. So as Americans live longer and have fewer children, fewer family members will be available for older adults to rely on the everyday help in the future. And as a result, we need solutions for financing, delivery, and long-term services and supports, and especially for family supports. So next slide, please. So this bar graph shows the projected family caregiver support ratio for the 15 southern states during the period 2015 to 2050. And while with the exception of 3 states, so they include North Carolina, Virginia, and Florida, over on the far right side of the slide, the 2050 ratio of potential family caregivers per person age 80 and older in the southern states is either at or above the national U.S. average of about 3 family caregivers per person age 80 and older. And while this may sound like good news in the grand scheme of things, it's not. And it's truly important here is the dramatic decline in the ratio of family caregivers for each person age 80 plus. So you'll recall from the previous slide that I mentioned that family caregivers are the backbone of long-term services and supports. And in 2013, about 40 million family caregivers helped another adult carry out activities of daily living, such as bathing, dressing, preparing meals. Family caregiving today is so much more complex, stressful, and costly for caregivers than ever before. Family caregivers report that the stress of caregiving affects their physical and emotional health, finances, as well as their jobs. So we need multiple approaches to help family caregivers, including such things as improved workplace flexibility, respite care, home care services, and better training. And solutions to support family caregivers will need to come from both public and private sectors. Next slide, please. Okay, so now I'd like to turn to talking points related to expanding home and community-based services and why it really matters. So federal law requires states participating in Medicaid to cover nursing home care to all who qualify, but coverage of HCBS alternatives is optional, but states can apply for federal Medicaid waivers to do so. And despite new programs under Medicaid, Medicaid in general has an institutional bias. And in addition, outdated and ageist prejudices assume that older people can only safely be cared for in a nursing facility. However, 90% of older adults want to remain in their homes and communities for as long as possible. So HCBS alternatives to nursing homes give people greater choice in how and where they receive LTSS. States can avoid unnecessary institutionalization by providing home and community-based services, such as home care, personal care, adult day services, just to name a few. And in 2014, 12.2% of nursing home residents in the southern states had low care needs. And that's well below the 11.5% U.S. national average. Nursing home diversion or taking steps to transition back to the community may be limited due to insufficient alternatives. States that provide a comprehensive array of culturally appropriate services that are designed to meet the needs of each individual are generally less likely to channel people to these institutions. And then HCBS is a cost-effective option to providing Medicaid LTSS. HCBS are generally less costly than institutional services, and on average, in Medicaid, the cost of HCBS per person is typically 1/3 the cost of institutional care. So next slide, please. Okay, so today, states are expanding access to an array of home and community-based services and are really working to reduce dependence on institutional care. They're starting to shift more to balancing really helps to assure that people with long-term services and supports needs have access to an array of services to meet needs and preferences. And while most states have begun to shift Medicaid nursing home institutional services delivery to offer more HCBS alternatives, states still have much more room for improvement. So the next slide shows a map of the U.S. and highlights where states were at in 2013 in terms of the percentage of Medicaid LTSS spending going to HCBS compared to nursing home institutional care. And in 2013, 44 states spent the majority of their Medicaid LTSS dollars in nursing home institutional care, and only 7 states in the District of Columbia spent more than 50% of their LTSS dollars on HCBS. So these are the states that show up in the dark blue highlights. So next slide, please. So this slide shows that the 15 southern states Medicaid LTSS spending balances from 2001 to 2013. So as shown in the bar graph, southern states have made progress in balancing their Medicaid long-term services and supports expenditures for older adults and people with physical disabilities during this time period. So the 2001 period is the blue column and 2013 is the green column. Unfortunately, the majority of states still continue to spend in excess of 60% of Medicaid long-term services and supports dollars on nursing home institutional care rather than home and community-based services. Next slide, please. And so my final topic addresses LTSS financing. And this pie chart is showing the percentage of 4 LTSS payer sources of total LTSS expenditures of a whopping $310 billion in the year 2013. And in 2013, Medicaid was the primary payer source, that was standing at 51%, followed by other public payer sources, which would include mental health, substance abuse, Medicare for long-term care, home health related needs. The LTS expenditures include spending on residential care facilities, nursing homes, and other types of home and community-based services. Next slide, please. So solutions are needed to address potentially catastrophic costs of LTSS. There's a very, very high outlay of public expenditures that individuals are just ill-prepared to for the high out-of-pocket costs that are in the skyrocketing 85 and older population, and of course with fewer and fewer family caregivers to provide that unpaid care. There's little dispute that the cost of long-term services and supports is just incredibly daunting. The typical cost of care in a nursing home is over $91,000 a year, and the average annual base price for assisted living is over $43,000. There are very few people who can accumulate sufficient savings, even over a lifetime, to cover these costs. And as a result, most people have to rely on families and friends for the bulk of their LTSS need. Yet, as I mentioned earlier, family caregivers are declining at a fairly significant rate. So new sources of both public and private financing are needed. We need a mix of financing sources that include both social insurance, private insurance, and savings, plus a strong safety net protections through the federal government. Government and individuals need to share in this responsibility, and these solutions need to be progressive, broad-based, stable, affordable, and capable of growing with enrollment. Next slide, please. I think that wraps it up. Thank you.
Fantastic. Thank you, Kathleen, for those insightful remarks. We'll now go ahead and move on to the next speaker. Anne, you're up.
Great. Thank you. Thanks so much, Roger. Great. Well, this is a great, Kathleen did a really nice job of teeing up what I'm about to talk about. And just to give everybody on the phone a little bit of context, here at the federal level, I'm in Washington, D.C., based in Washington, D.C., and I've been working with a number of different groups, including AARP, over the last few years to do research and develop options for financing long-term care going forward. So Kathleen really laid out the need for financing, and I'm going to talk a little bit about the risk of needing long-term care that exists within the older adult population, and the financing options that several of the groups here in DC that have been working on this issue for a long time have come up with as a result of the research. So, and again, this is a federal perspective, but there are many lessons I think that can be drawn from this for the state level. I'm happy to talk about that more in the Q&A. So first of all, if you go to the next slide, please. Thank you. Having a need for long-term care, meaning the eventual possibility that you might have the inability, be unable to perform multiple basic activities of daily living, is a risk that we all face. This isn't something that you can expect as a natural result of old age, but rather it's a risk that we face. In other words, of all of the people, the research that we did show that of all of the older adults who are turning 65, will at some point over the rest of their life have a need for 2 or more activities of daily living assistance. So you can go to the next slide. But women, when we break that down by gender, women in fact face a much higher lifetime risk. Women, compared to men, are much more likely to have a need for support and services around the functional impairment or the inability to function in their daily lives. You go to the next slide. But that need, that doesn't necessarily, it doesn't have the same duration for everybody. So what I mean is, if you picture in your mind right now a room full of people, and you cut that room in half, and they're all, imagine that they're all turning 65 tomorrow. You cut that room in half. Half of that room will at some point, as I said before, have a need for long-term service and support over the rest of their life, and the other half of the room will not. But of those who have the need, some of them will have that need for a very short period of time, less than 1 or less than 2 years. But there's a portion of that group of people who will have need that lasts 2, 3, 4, and upwards to 10 or 15 years. So we know that 15% of all of those who are turning 65 tomorrow are in fact going to have a high need for long-term service and support that's going to last for 5 or more years. Let me go to the next slide. And we see the expenses related to long-term care need distributing themselves much the same way. So there's about 15% of the population, of the over age 65 population, that faces the risk of having very high long-term care costs over a lifetime. And so just to put kind of a picture on this for you, many times, in many cases, these are individuals who have dementia or Alzheimer's and live for very long periods of time with the disease and face significant expenses related to their care. The other issue that's going on is that even though we are living much longer, but we are living longer also with as a result of that, with longer periods of what we call morbidity. That means longer periods of time where we are unable to function or living without our full health. And so as a result of that, we face significant expenses. But the risk of facing that is not a certainty. In other words, again, it's not something that every single one of us can expect as a result of old age. There are going to be people who are going to live into their old age without any need, and there are going to be those who have significant need and significant expenses. So this is what we call an insurable risk. So you go to the next slide. Okay, so how are these costs that I just showed you, how are they financed? So how do we pay for the care? Well, let me just say a couple of things about the model that we did, because in Kathleen's presentation, she showed you a distribution of long-term care spending by payer source that the Kaiser Commission on Family, Kaiser Commission prepared. And the difference between that data and the data that I'm showing you is that this data, which was analyzed by the Urban Institute last year, includes spending on residential care, much of which is out-of-pocket, private and out-of-pocket dollars. So the Urban Institute, which the CMS data that the Kaiser Foundation relied on, does not. So when we actually include residential care, assisted living, independent living in our analysis, we see that in fact, over a lifetime, all of the services, home care, residential care, and nursing home care, of all of those services, about 52%, this is the top bar, are actually financed by out-of-pocket spending. And 34%, which is still a very big percentage, is financed by Medicaid. When we look at home and residential care exclusively, there's a much bigger percentage that's financed by out-of-pocket, not surprisingly, whereas Medicaid is financing a much bigger portion of nursing home care. If you can go to the next slide. And as Kathleen talked about in her presentation, what's really striking is the significant contribution of unpaid family caregiving. When we look at any point in time at the older adults who are living with significant long-term care need, what we see is that 2/3 of them are in fact being cared for exclusively by a family caregiver. So all of those dollars that I just showed you are in addition to the unpaid family caregiving that's going on, and for many adults at any one point in time, that's the only care that they're providing. Go to the next slide. So the research that I just showed you was reviewed by 3 different groups in Washington, D.C. who were working on new insurance-based options for financing the long-term care need of this country. And the reason why they were focused on insurance is because the analysis that we did showed that long-term care need is a risk that we face as opposed to a certainty, and therefore lends itself better to insurance-based solutions as opposed to savings-based solutions. So you go to the next slide. So let me talk first about the groups, and I should mention that AARP was in fact involved in funding the research that I just showed you and the work on the policy options and the analysis of the policy options I'm going to show you. But there were 3 groups who in fact published reports in February of 2016. All of these reports can be found on the SCAN Foundation website. And these 3 groups, the Bipartisan Policy Center, Leading Age, and the Long-Term Care Financing Collaborative, which is a group of Republicans and Democrats who got together to work on solutions to long-term care financing, all drew some of the same conclusions, or came to some of the same conclusions, which is that there is definitely a role for private insurance first and foremost, most likely to cover a short-term period of need that occurs at the front end of risk. So in other words, those first couple of years that you have a need for long-term care, the private insurance market was well designed to in fact help pay for some of that care. But that we need to do more to improve the affordability of these products, to ensure that individuals can enroll through their employer through mechanisms like auto-enrollment, and to expand the use of retirement accounts to purchase the products. So all three of the groups drew very similar conclusions about the role of private insurance. If you go to the next slide. But they also came to the conclusion that there's a role for the public for a public program to provide coverage of the catastrophic risk. Meaning, if you remember back to the pie chart that I just showed, that there's a smaller portion of the over age 65 population that faces a risk of needing long-term care for 2 or more years. And for those individuals, really the only effective or efficient way to ensure against that risk is through a public program in which everybody is enrolled, so that everybody is sharing risk. All three of these groups, 2 of which were bipartisan and 1 of which is a provider-based group, supported the concept of universal insurance as having the biggest impact both in terms of reducing Medicaid spending and in terms of reducing out-of-pocket spending and in providing more dollars overall to pay for care. So we go to the next slide. So let me explain what I mean by this just a little bit more. So there are really 3 approaches to covering risk. One is that from the point at which, and these are all really time-based approaches. So in other words, we could create a comprehensive program of insurance in which at the point at which an individual or older adult would need care at the level of 2 or more activities of daily living, meaning somebody is unable to perform 2 or more bathing, dressing, eating, getting in and out of bed, these really basic life activities. When 2 or more of those are, when they can no longer perform 2 or more of those, the comprehensive insurance would begin, and an individual would receive a certain amount of money per day, and that benefit would be available for the rest of their life. So that's one approach. Another approach is to provide what we call front-end coverage. So that's just to cover the risk over the course of 2 years. And if you remember, most people actually die before the end of 2 years is up when they have that level of need. And so, an insurance policy that covered 2 years at a certain amount of coverage, dollar amount per day, would in fact, that would cover the most people. But another way to do it would be to have catastrophic insurance available for those people whose need lasts more than 2 years. So it would be a catastrophic insurance coverage that would cover the need from the point at which they had been having a need for care for 2 years throughout the rest of their life. So we go to the next slide. And what we found was that, so in addition to looking at those different types of coverage options, comprehensive, front-end, or catastrophic, we also asked ourselves the question, can we design insurance that's voluntary, in which, that would have a big impact on the way that we finance care today, or do we have to require that everybody enroll in some level of insurance? And what we found was that if everybody were offered the option of enrolling in an insurance program, and in fact that option were subsidized for low-income individuals, we would see a reduction in Medicaid and out-of-pocket savings of only about 4%. So in other words, it's really hard to move the dial on Medicaid spending or out-of-pocket spending through a program where individuals are given an option to enroll insurance, just because just not enough people enroll. But when we assume that everybody enrolls, in other words, there's some requirement that everybody enrolls, we see savings to Medicaid and out-of-pocket of about 27%. So go to the next slide. Now, if you were to assume that we adopted a mandatory approach, you can choose between a front-end, a catastrophic, or a comprehensive mandatory approach. And of great interest, I'm sure, to people who are on this call The Medicaid program is really a front end, not surprisingly, insurance that covers only the first 2 years of your need is not going to have that big of an impact. Even if everybody's enrolled, it will not have that big of an impact on Medicaid. And that's because Medicaid now, today, typically tends to kick in much farther along in somebody's trajectory of need. So, after they've had that level of need for a long period of time. And so that's why we see a catastrophic mandatory program is having one of very close to, if not, in comprehensive, is having very big impacts on Medicaid spending. That is, we estimate that they can reduce Medicaid spending annually in the some years out after everybody's enrolled by about 28 to 32%. We go to the next slide. Okay, and so what this slide shows is a spending breakdown across different types of payers for each of the options that I just presented. So assuming that the programs were mandatory, how would the distribution of spending shift over time? And so I would just call your attention to the catastrophic mandatory option, in which 30%, so the financing of care, which was under the current system is only 2% of which is long-term care insurance, would become 30%. And the Medicaid contribution would drop from 41% to 27%. And at the same time, total spending would, in fact, average lifetime spending would, in fact, go up. And that's because there's more insurance dollars to pay for care, so there's more care provided. And we estimated that option could be financed through a Medicare payroll tax of about 0.75%. Go to the next slide. So we just provided here, and I'm sure Roger can provide these for you. These are sources for all of the different research that I presented today, and they're all available, again, on the SCAN Foundation website. So thanks.
Great. Thank you, Anne, for that excellent presentation. Very good work. All right, we will now move on to our third and final speaker, Jeff Lunardi. Jeff, please go ahead.
Thanks so much, Roger, and thank you, Kathleen and Ann, for leading us off. I'm hopeful that this third component will kind of complement those other two really, really well. So just to provide just a bit of context, my goal today is more to provide a case study of how Virginia is currently working to provide Medicaid-funded long-term care as cost-effectively as possible. So I'm going to touch on just a couple of key points from a very recent study that our agency did, which is JLARC, which is kind of, it's analogous to GAO at the federal level. We're the legislative kind of policy research and oversight agency for the Virginia General Assembly. And we were given the task a couple of years ago of taking a very broad look at Virginia's Medicaid program and basically trying to answer the question, how can we provide Medicaid more cost effectively? Virginia is not unlike just about every other state where Medicaid is occupying a greater proportion of state budget dollars, particularly general fund dollars, on a year-over-year basis. And so that's becoming an increasing concern for legislators, and so that was kind of the impetus of the study. So I'm going to touch on kind of a small slice of what's in the broader study, and really two of our key findings from the long-term care area, and touch on how they're being acted upon actually right now in the current General Assembly session. So if we move to the next slide, just a bit of background or a bit of context on Virginia's Medicaid LTSS spending. As you can see, certainly growing over the last 5 years, and that's really being driven, and I'll show this in a little more detail on a slide in a couple of minutes, but really being driven by just more recipients. There's frankly, as the population ages, there are more and more Virginians in need of long-term services and supports, and more of them who are kind of exhausting their own resources and turning to Medicaid as the payer of those services. But the other key point here, kind of leveraging what Kathleen talked about, is Virginia has seen a continued shift toward more cost-effective home and community-based services. We certainly believe there's more room for improvement, and that's really, I'm going to focus on that in the second portion of my slides here in a minute. But we've seen some success over the last 5 years, and that's really tempered some of the potential growth as more recipients have come in. the shift to more home and community-based alternatives has at least tempered some of that growth. But even given that, at $2.35 billion and half of that coming from Virginia's general fund, it accounts for about 5% of Virginia's total general fund budget, and that's not total Medicaid, that's just Medicaid LTSS. So I know that's not unlike many states out there, and so certainly it's something that our legislators are focused on. And so the two things I'll focus on today are, number one, from a Medicaid perspective at least, it's critical that the screening, the functional and medical screening, assessing individuals' activities of daily living be done consistently across the state to ensure that the right people are eligible for Medicaid and that they're treated equitably across the state. And then once you've identified those individuals who are eligible for Medicaid, serving more of them in the community, which on average is less costly and in many cases results in better health outcomes, is a really, really pivotal strategy for states in making sure they're being as cost effective as possible. So I'll launch off with a couple slides on our work on the eligibility screening process. If you move to slide 3, the crux of this for us is we looked at the fact that just more recipients was driving cost growth in Virginia. Our legislators wanted to know, are we doing a good job of screening those recipients that they meet our level of care requirements? And Virginia's level of care requirements are fairly high for Medicaid. There's a couple different permutations, but in short, you have to have at least be dependent on at least 4 activities of daily living, which, as Ann was talking about, a lot of the models she was talking about were based on two ADLs. Virginia has some fairly strict criteria. And in looking at making sure Virginia's resources are used appropriately, it's important that be done consistently and reliably to ensure that all applicants are treated equitably across the state. But then that's also the point of contact, the first point of contact and the first choice that the recipient makes as to whether or not they're going to receive care in the community or in an institution. And so making sure that screening process provides informed choice to applicants once they meet that level of care. It is a critical component in starting folks off where they want to be and in the most cost-effective setting possible, because it's much more difficult to transition someone once they're in an institution than it is to start them in the community and build those supports from the beginning. So the next slide, slide 4, just shows a very quick snapshot from the last fiscal year. So what this is, this shows the percent of applicants that were screened for long-term care that were approved for services, that were determined to meet the level of care across the state. So the way Virginia assesses level of care need is it's done by 117 community-based teams, which are in our local offices of social services in counties and cities across the state. And then it's also done by hospital discharge teams. And you see the numbers there. Just the number of different screeners is kind of an inherent challenge in Virginia's system. There's 117 community-based teams and 91 acute care hospitals that are potentially screening recipients each year. And while the numbers on their face don't demonstrate that things are not reliable, the wide range of results without kind of other factors that we could point to definitively say are driving those differences was concerning to us, as you can see, as low as 37% in one locality and all the way up to 98% in another, and then even within hospitals, slightly narrower range, but 68% up to 100%, and that's only in localities and hospitals that screened at least 100 individuals in that fiscal year. So we were looking for kind of significant enough sample size. And so, we kind of were left with 2 choices for our research. One, we could bring someone in with the expertise to actually rescreen individuals and kind of perform the type of validation that would need to be done, or we could focus on the process and kind of look at what supports and training are in place for those screeners to ensure reliability. And so we went with the second tactic and looked at kind of how the process plays out. And what's being done to ensure that those screenings are done in a reliable fashion. So if you turn to slide 5, there are 3 components that we identified really needed to improve. And this was done in consultation with a consultant who had expertise in this area, who was able to help us identify what some best practices were in terms of these functional screenings. And so the 3 things we identified that needed to improve in Virginia were was that training for screeners on how to use Virginia's screening tool is not consistent or even mandatory. So there are several trainings that are available through different state agencies, and it also wasn't mandatory. So not everyone was being trained before they were going out into the field and conducting screenings. On the back end, there's no current inter-rater reliability process to kind of what I talked about was one thing we considered doing, but to go back and test, and basically, you can kind of rescreen right after the initial screening to see if two people, come up with the same results and that they're interpreting the responses from the recipient accurately and appropriately. So there's not that back end kind of statistical test to demonstrate that screenings are reliable. And then there has been a lot of work on overseeing this process in Virginia recently, but it's actually been very much focused on getting screenings done in a timely fashion, which was a significant problem in Virginia going on 3 or 4 years ago, that individuals were in need of screenings, in need of LTSS, but because of the workload, they weren't able to be screened right away, and so that was holding up them being able to get these needed services. And so there has been a lot of efforts and a lot of improvement, I'm happy to say, in Virginia on improving the timeliness of screenings, but there hasn't been that level of focus on ensuring reliability. And so we felt that a lot more needed to be done on the oversight front to make sure that these things were happening. So our report, which just came out in December 2016, had several recommendations addressing these topics. And so on slide 6, I just wanted to touch quickly on kind of the steps Virginia is taking in response to that to ensure reliable screenings. There is proposed legislation in the current General Assembly session to develop a single comprehensive training curriculum for Virginia's assessment tool, which is called the Uniform Assessment Instrument, and to require all screeners, anyone who's going to be screening recipients for LTSS to undertake that training and then also be certified by our state Medicaid agency prior to going out into the field and conducting those screenings. Secondly, there's some proposed language to implement an inter-rater reliability process, which will provide much more kind of rich and robust data to tell us whether or not we have problems in certain areas. Going back to that chart of the variation between localities and hospitals. Some of that may be perfectly reasonable just based on the levels of need in those different localities, but some of it may not be. And so inter-rater reliability would provide much more rich, valid data in order to assess really where we are as a state in doing this consistently and reliably. And the final thing, and something that we're certainly happy about, is that our General Assembly, even in always difficult budget times, has at least proposed some additional funding for all of this, including some positions for improved oversight of the reliability of screenings, because it is a challenge that needs to be, we thought, invested in. Conducting inter-rater reliability costs money, and it requires people's time to do the types of analysis, to go out to the localities, the hospitals that appear to be having trouble and provide the technical assistance, and then certainly to develop and implement the training. So we're certainly happy to see that funding coming along with the requirements to try to improve that process. So the next thing I'll touch on is shifting to, once you've identified your eligible recipients for Medicaid long-term care, is making sure that we provide that care in the most cost-effective way. So if you go to the next slide, we see that obviously, as Kathleen has touched on, serving recipients in lower cost community settings is really the greatest lever that states have to improve the cost effectiveness of their LTSS. And so, in Virginia, the annual cost per recipient for community-based services is $12,000 less than in a nursing facility, and there's certainly research that indicates recipients have better health outcomes when served in those settings. Next slide, please. So this table really bears that out, and it's actually a bit of just a drill down of that very first chart. It's a little busy, but highlight a couple things. You see average enrollment in all institutional settings in Virginia Medicaid has been flat, actually slightly down over the last 5 years, just under 20,000 in FY11 and 19,300 in FY15. And home and community-based services average enrollment increasing from 29.5 just 5 years ago all the way up to almost 42.5 in FY15, and you see the cost differential there. The reason it's different from the figure on the previous slide is this includes also the intellectual and developmental disability waivers that Virginia handles. But so the numbers are a little different. But as you can see, the average institutional cost has been relatively flat, going from $52,000 to $50,000. But the real key here is that as the shift has gone from institutional settings to community-based settings, we're spending, more people are in those more cost-effective settings. And so that very bottom line, you see overall total LTSS spending per person has gone down from $41,700 5 years ago to $38,100 in FY15, and that's not adjusted for inflation, and so it's certainly a positive indicator, but certainly our research indicated that more can also be done. So if you move to the next slide, there's two things that I wanted to focus on strategies Virginia can take and is hopefully currently going to be undertaking after this General Assembly session. Going back to the point that the pre-admission screening, the functional screening is kind of that first touch point where an individual chooses their setting of care. We looked at the percentage of applicants that were recommended for nursing facility care versus community-based care between those done in hospitals and those done in the community. And as you can see, it's a stark difference. So those done in the hospital, 80% of them recommended for nursing facility care. Those done in the community, just 12%. And now there are plenty of valid reasons why individuals screened in hospitals may need to go to an institution at least temporarily. They're obviously in the hospital for some sort of acute medical need, and so at least their short-term needs may be higher. But it raised the question, because even though it's ultimately the recipient's choice as to the setting they choose, it wasn't clear to us that the screenings being conducted in hospitals were providing informed choice to those recipients and taking the time to develop all of their options. So we dug a little deeper and we talked to some of the hospitals. If you move to the next slide, please. We talked to the hospitals who are conducting the screenings and the discharge teams, and this is what they told us were the biggest challenges, and we were thrilled that they were kind of as open as they were about it. But number one, they said it's very difficult to assess an individual's long-term needs when they're hospitalized for an acute condition. So the goal of the long-term care screening is to identify their ongoing needs, but when their medical condition is they're kind of recovering from an acute episode, that can be very difficult. The other thing they mentioned was that screening an individual in a hospital room, it's very difficult for the discharge teams to really get a good sense as to whether that individual can function safely in the home, and which can sometimes lead them to kind of risk-averse choices in terms of their recommendations. And then finally, hospital staff, frankly, just are focused on discharging the patient as quickly as possible and as safely as possible to the next setting. And so in many cases, given the difficulty in assessing their long-term needs, given the fact that it's hard to really get a handle on what community resources may be available or even family resources, oftentimes a nursing facility is a faster option for discharge as well as a more risk-averse option from a patient care standpoint. And so these are all issues that we recommended be addressed as Virginia moves forward. And then the last thing I'll touch on, if you move to the next slide, in terms of being able to rebalance in a Medicaid program, is Virginia is just in the process of launching a managed long-term care program. So basically moving all of its LTSS population under a managed care delivery system. And I won't get too technical, but essentially there's several different ways to structure capitation rates that are paid to the health plans that will participate in the program. And one is called a blended rate, and CMS recommends this rate, but this essentially pays MCOs based on an expected percentage of recipients they'll serve either in an institution or the community. And so it creates a very strong long-term incentive, and Virginia used this blended rate in its dual demonstration program over the last 3 years. But what they didn't do that we found was they didn't establish a target mix. So from an actuarial standpoint, they were calculating what it costs in the community, they were calculating what it costs in the nursing facility, and they were trying to set a mix that would just align with what the health plan's experience would be. And that's not exactly what CMS recommends. What the goal is to look at that and say, well, if right now your population is 50% community versus, or 50% institution versus community, we want you to move to 51% community, 49% institution. And so that obviously, the weighted average will lower the overall rate you're paying the health plan, and we'll put that incentive in place for them to divert new recipients as well as transition the ones that they have. So, so on the next slide, again, just we're happy to see there's at least some proposed legislation addressing this in the current session. There's some funding provided to really get in and assess whether hospital screenings in Virginia are leading to unnecessary institutionalizations and develop some concrete solutions for that. And then also to require our state Medicaid agency, as they launch managed LTSS, to use a blended capitation rate with that key target mix to incentivize MCOs. So my last slide there is just my contact information. Some of this stuff gets fairly technical, and it probably really depends on how your state does pre-admission screenings or whether or not you're a managed long-term services and support state. But if you are interested in finding out a little more about what we did, feel free to reach out to me.
All right, great. Thank you very much, Jeff. So it looks like we've got a few minutes left before 3 o'clock, so we're going to try to get through a few questions that we've received. And the first question is for you. You mentioned the significant savings a mandatory long-term care catastrophic program could have on Medicaid. Was any sort of mandatory program considered when the ACA was being written and implemented? And is there any hope for such a program in a new health law that might be adopted by Congress?
Wow, that is a great question. Really good question. So no, the answer is that there was not such a program considered when the ACA was originally drafted. And in fact, what was included in the original ACA legislation, and actually what was passed and signed into law, was a provision called the Class Act, which was a sort of a public social insurance program. The problem was it was not mandatory; it was voluntary, and the structure of it was such that ultimately HHS decided that it wasn't sustainable. That is, it would just kind of die under the weight of an actuarial death spiral because of the the inability to really spread the risk through that program. And as for what might happen with any kind of additional sort of legislative activity around health insurance reform, I think there's on the one hand it's very challenging to talk about any kind of a mandate, obviously, but on the other hand, I think there's some interesting potential framing of this issue that is different in the sense that this is an issue that really affects families. It affects family financial strength. It's it's really kind of needed to build up the infrastructure of our country to actually deliver aging services. So I think it's tough, but I remain optimistic.
Great, thank you. Kathleen, the next question is for you. You talked a lot about the critical role unpaid caregivers play in providing long-term care to friends and family. Are you aware of any measures at the state or federal level that have been taken or at least considered to support caregivers? Any kind of financial benefits such as tax credits or professional benefits such as approved leave from work?
Yes, and yes. With respect to federal tax credits, this is something that AARP is very interested in pursuing. It is something that we have included in our annual policy book as an issue that we are really trying to work through, with our federal partners. Whether or not that's going to happen, in the next year or so is a big question mark, but it's certainly something that we are actively pursuing. And there are other areas that we are strongly promoting, and that includes respite care. Respite is a benefit that's currently made available through the Older Americans Act. However, funding is very, very small through the federal government. There are a number of states who are trying to promote respite care through various types of state-specific funding, as well as volunteer arrangements and so forth. But it's very much a grassroots type effort. But it's something that I think this is definitely an area that requires very, very diligent federal as well as private as well as state partnership on. And then the other area that that was addressed relates to work-related benefits, and this is something again that AARP is really trying to work with states to make this available. There are a number of companies that are taking these initiatives, beyond the state level. I know a number of very, very large, firms such as the large accounting firms. I believe Microsoft, has developed their own family caregiver related benefits. AARP recently made this available to its employees. But again, we at AARP are really working to try to promote this at both the state level. So hopefully that helps. I mean, we're inching towards these initiatives and really trying to get the message across, but it's something I think that's going to take much, much more time. So we're taking baby steps.
Perfect. Thank you very much. And we will do one more question, Jeff, for you. It may require some speculation on your part. What impacts on Virginia do you foresee if the new administration and Congress decide to make significant changes to Medicaid? Specifically, do you believe any changes to Medicaid may have an impact on the way Virginia administers funding for long-term care?
That is a really good question, and actually one that Virginia is wrestling with at this moment. Unfortunately, in terms of a specific impact to long-term care, I'm not sure that I've heard any federal proposals that I can kind of clearly or responsibly kind of speculate as to what they might do to Virginia. I know our Medicaid agency has been asked this question throughout our legislative session, and obviously one of the big talking points and potential proposals is to roll back, if not repeal, the Affordable Care Act. And one provision in there that would really, really hurt Virginia as a heavy managed care state is the Affordable Care Act allowed states to collect supplemental pharmacy rebates from its managed care for drugs that are paid for through managed care delivery systems. And so that's been a significant source of revenue is the wrong term, but a significant source of additional supplemental rebates and savings. And if that were to go away, that would certainly be a shot to Virginia's budget in terms of the lost pharmacy rebate. So that's tactical and not long-term care specific, but I guess what I would point to just in terms of thinking about that, Virginia's General Assembly is starting a bicameral commission, so a joint commission is what we would call it, of members of the House of Delegates here in Virginia and the Virginia State Senate to kind of look at and oversee these issues over the next year or two, and they're going to be holding meetings and leveraging staff from our Senate Finance and House Appropriations Committee, as well as likely leveraging us a little bit to try to understand what any concrete proposals that start moving in Washington may do and what impact they may have on Virginia's program. So I'm not sure that really answers the question, but I think that's about as much as I can kind of intelligently say, given the uncertainty of what may or may not happen in D.C.
Sure, makes sense. All right, thank you. Okay, so we are a few minutes after 3 p.m., so we will go ahead and wrap up the program. If there are additional questions, you can forward those to me, and I will work on getting responses from our presenters. You can send any additional questions to rmoore@csg.org. That's the letter R, M-O-O-R-E, @csg.org. Thank you again to our presenters for their contributions this afternoon. I also would like to thank Lisa McKinney for all her help in making this webinar a great success. And lastly, I thank all of you for spending an hour with us this afternoon to discuss this very critical issue. I hope you found the information both useful and informative. If there is anything that CSG or SLC can do for you, please do not hesitate to contact us anytime. Everyone, have a wonderful afternoon. Thank you.